Okay, let's talk about managing urinary diversion systems. So, what we have here is a person who has a plumbing problem. They may be creating urine, their kidneys are fine, however, the excretion of that urine, the whole system is broken in one place or the other. Some of the risk factors for needing a urinary diversion would be, say, a birth defect, cancer. In fact, I have had several patients who have had cervical cancer, maybe even colon cancer, and they need a place for the urine to divert because cancer was all surrounding and invading the tissues that normally would, excrete the urine. But trauma would require you to have a urinary diversion, and just general disease of the urinary system, such as if you had too many kidney stones or too many prostate frequencies of obstruction. They would go ahead and, instead of straight cathing you all the time, would put in a urostomy. There is a couple of different diversions that you can place. I believe a few slides forward are going to describe that to you, but what you see in the pictures here under risk factors of recognition is a nephrostomy tube. And so this is a tube that goes directly through the skin into the back of the patient, directly into the kidney, so the urine exits that way instead of going down into the ureters, into the bladder or the urethra. So how do you know if somebody needs a urinary diversion? Well, they have kidney failure evidenced by their blood screening. In fact, you would usually do what we call a BUN, blood urea nitrogen level on them, and a creatinine. Creatinine is a byproduct of muscle action and metabolic processes, and the kidneys, normal healthy kidneys, actually excrete the creatinine, but in diseased kidneys it actually retains, it's unable to excrete the creatinine. So we can actually measure how somebody's kidneys are doing by looking at their creatinine level. The BUN, the blood urea nitrogen, is also another way to see how well the body is peeing out the urea and the nitrogen. And if it's not working, you can then tell that the kidneys have a problem. There's a few different reasons why you would have a high BUN and a high creatinine other than kidney disease, but we're going to use those two lab values just for the purpose of saying the kidneys have failed. Like if you're dehydrated, one of those levels would go up, or if you had a really bad imbalance of protein intake, like too much, your nitrogenous waste one would go up. But we're talking about kidney failures today. Anyway, so little to no urine output. We would have somebody start to swell up. All of the water's got to go somewhere, and it goes into the tissues whenever it can't go elsewhere. So somebody will start having facial edema, arm edema, fingers, hands. They'll say that their rings don't fit anymore. Their shoes are too tight. So edema will be everywhere. They can also develop urinary problems through having the kidney stones I mentioned. You can see it on CT, MRI. Then we need a urinary diversion. Also on an ultrasound, that's what U/S means. Ultrasound, we'll see hydronephrosis. This means water on the kidneys, or urine is backed up. Gotta go out, gotta get out some way, somehow. So the complications of having a urinary diversion is hydronephrosis. Wait a second. How would hydronephrosis be the complication if it's also the problem? Well, if you only have one way for urine to get out, and say it's your tube and it's occluded, maybe it has junk in it, protein, maybe they have a UTI, so it's kind of chunky, but you can actually also cause hydronephrosis by fixing somebody's hydronephrosis. So that is a real complication. Infections, anytime there is a surgically made hole in somebody, you're at risk for infection. Psychologically, this is really, really challenging. We sort of mentioned the sexual aspects of it, but just going out to eat with friends and knowing that you are currently urinating through an ostomy bag worn, under your shirt, you want to teach patients how to wear certain articles of clothing to disguise and hide some of these appliances underneath the gown, underneath their shirts, like an empire waisted top that flows. The attitude of the healthcare worker is extremely important, because you will notice that unfortunately a lot of people are not trained or don't remember how to properly care for one, so they will apply the device incorrectly, or they will empty it infrequently, and the person will have what we call blowouts, which is where the device pops off. Also, just their facial expressions are not under check and control, so they'll be, making faces as they're dealing with something. I mean, nobody wants to have a nurse working for them that's like this. It's disgusting. No, it's not. It's just a diversion device. It happened to you. Slide 23, please. Here we have an example of two ostomy devices. One is a little bit more of a, what's the word for it? The stoma has the correct, not inversion, extraversion, I guess. This is the one on the left. It's kind of, pooching, the intestines flipped out. As you can see, it's actively making urine. There's urine streaming down the body. This looks like it's for a kidney removal. Now, the orientation, if I had to guess, the belly button on the left is the top part of the person, and as you move to the right of the picture, that's their pelvic area, which is well shaved, so that's why there's no pubic hair. But it looks like they took out a kidney here, or even replaced a kidney. They even have a drain hanging on the left. But we don't want to measure the peri area, because on the right this can happen. The stoma is actually a little bit more on the inside. It's kind of an inverted stoma, and this happens whenever it's not just tacked down correctly, or the surgeon makes it at the flush with the skin. It's supposed to kind of pooch out, flip out some. But here we have trouble for the nurse, because the stoma has to be cut just right to allow that skin to heal. So you don't want the, how do I describe this? If you have the stoma, you want the ostomy device to fit perfectly around it, not too big, because then that peri area begins to get excoriated, like as you see in that picture on the right. Or if it's too small, the urine will get under the wafer and the applicant and the device, the urinary diversion, pouch, and it will cause a larger area of excoriation and the device to malfunction. So it has to be just right. This is a situation where we would call an ostomy nurse, who has lots of resources and training, and she can train you how to apply and troubleshoot a device like this. That person looks like had multiple surgeries, as you can see. This is evidenced by the large scar down the middle of the abdomen. It's quite a large scar. Wide, I mean. So keep the skin clean, keep it dry. A lot of times you can apply barrier ointment. Not ointment, it's like a pad that you paint on somebody before you apply the sticky ostomy device. It helps keep the skin intact as well. All right, assessing urine. This is slide 24. Monitor ins and outs. Can a tech monitor ins and outs? CNA, a tech, whoever? Yes, actually they can. And the reason being is they are just collecting data. They are not assessing the data. They are just gathering the numbers for you, such as they would be gathering vital signs or blood pressure. This is within their scope of practice, but it's your job to read the numbers, interpret the numbers, and to communicate a problem to the physician or provider. As you see in the upper right-hand portion of the slide, I don't know why I'm leaning so far forward. Like you really need that close-up of my face. But in the right-hand side, this is how you would collect a freshly voided specimen. If some doctor wanted like a sodium or urine protein, it doesn't necessarily need to be sterile, but we call that a hat. Don't ask me why, I'm just telling you the facts. But they call this a hat, and you would put the patient's name on it, date, time of collection. Once you've collected the sample, you would transfer the urine into a hat and pour it into a little specimen cup. Now, if you need a urine sample, such as a urinalysis, or to perform a urinalysis, the doctor would say, give me a clean catch. And what this means is that you actually have the patient clean the perineum, male and female, and they pee a little bit. This actually washes all of the film of bacteria that's on the meatus away, and you take the little cup and you catch the middle of the stream. So not the first pee, not the very end of the pee, you catch the middle piece of the pee, and that's the middle part of the stream, I should say. That is the most accurate way to collect a sample. And then you clean with a little peri wipe afterward. So wipe before, pee a little bit, get your cup in there, got it, pull out and let them continue pee, and then you wipe the remaining of urine after them. But that's very important. A lot of times we just give the cup to the patient and say, give me a urine sample, and they don't understand we want a midstream. That is the only acceptable way to collect a clean catch. Now, they may not want a clean catch. They may want a sterile urine specimen. This is only completed by going in with a urinary catheter. You're sterile. You clean it with the betadine wipes, collect your urine, and then you pull out. And there's no first part of the urine or last part of the stream. You're going into the bladder, so there's no stream to collect. But that's called a sterile specimen. Then we've got the 24-hour specimen. This is when the doctor is trying to figure out in a 24-hour period how much urine you're producing, how much protein is in there, how much creatinine is not being processed by your kidneys and it's showing up in your bloodstream. And they do this little comparison of how good your kidneys are or are not doing. But that urine is a very, there's a very specific way to collect this urine. You say, okay, 10 o'clock, pee, and the patient pees, you discard that one, don't keep it. And then the next one, 10:30 when they pee again, you count that one all the way up until 10 o'clock the next day. The big catch here is that you discard the first pee after your designated time. What happens if a tech throws your pee away accidentally? Ooh, I didn't know you were collecting a 24-hour urine. There was no sign. You forgot to put one. What do you have to do? You start all over again and have to explain yourself. Why? All right, patient. So about that urine sample I was trying to catch on you, yeah, we have to start over. So put signs up, communicate to your techs and to the rest of the healthcare team that are taking care of this patient. Don't throw my pee away. All right? Keep it. All right. That's it for that one. Oh, and you have to keep the pee on ice. Yeah. Keep the pee on ice, please. That can be something your tech can do to, continue to monitor that and get new ice. Crushed or cubed? All right. Slide 25. All right, common urinary studies. So to understand what's going on with a urinary elimination, you've got the physical signs of the patient. You've got what they're also telling you, the subjective info. But we can also understand the patient's situation a little bit more by running some diagnostics on them. Easiest one to do is the dipstick or the urinalysis on them. So there's a couple ways to do it. You can actually take a little stick that has little pieces of paper, and they're all measuring different things on the different dipstick, or on the dipstick. You have to take the stick, you dip it in the urine, and when you pull it out, you usually set the timer for like 3 minutes, and that's whenever you take the reading. So the urine has time to change the color of the paper. And as you see in the picture there, you hold it up to the bottle, and you can see what we call a macroscopic look at what's in the urine. So do I have presence of white blood cells? Yes or no. Is there a lot or a little? It doesn't tell you how many, but it'll just say like 3+, which would be a lot. Do we have glucose in the urine? A lot or a little? And it will actually, you just match up the colors. It's not too challenging, but you got to be fast at this because the longer you take to read it, the more the colors fade into something different. So it's kind of a imprecise way, but a good estimate to see what's going on with the kidneys because you tested the urine. You also need really good lighting to be able to see this, see the reagent develop. So that's kind of a downside. There is something called spectrometry. That's used less often, but that's using light going through the urine, and it can tell you if you, it will tell you the same thing like a urinalysis, I believe, when it comes to specific gravity, actually, specometry. But it's not as commonly used because the dipsticks, kind of gets the job done. And it's a little bit faster and cheaper. Let's see, specific gravity. This, to really explain specific gravity, I think of how many solutes are in the urine. If there is, there's a lot of solutes, there's, it's kind of thick, for lack of better words. If it's thicker, then your specific gravity will actually go high. If it's greater than 1.030, there is a trailing zero here in this situation, okay? We're not doing medications, it's just how this, number is reported. But if it's greater than 1030, we say that the person is actually dehydrated because the urine is really amber, it's thicker, it's got more solutes in there, so the specific gravity is higher, we say. The only way I can remember this is I tell myself if I haven't peed by 1030, then my urine is going to, have high specific gravity. It's going to be more concentrated. But normal is like 1.005 to 1.010. So 10, yeah. All right. There. Don't really need to remember those numbers for this test, but it will help you in PCT too. All right. Pyelogram. You can either check out the kidneys and see how they're filtering things, either by giving somebody direct push of IV contrast. You must know if the person is allergic to shellfish. This is a problem if they are allergic to shellfish or iodine, sometimes even betadine. They could be that sensitive. Betadine is a pretty distant cousin, but of the iodine families. In terms of reaction, how severe is the reaction will determine if you are going to do the study or not. They can actually give you a couple of medications to desensitize you, but more than not, if you have a pretty bad reaction, the doctor's just going to avoid a contrast dye study. So you can do IV dye, put into your veins. The CT machine will circulate or it will take pictures as the dye is circulating through your kidneys, so you really get a good look at your kidneys. Or you can actually do a retrograde or direct pyelogram. This is where you will actually put in a catheter up the urethra up into the kidneys, and you'll shoot dye that way, and we'll see how it looks. Sound good? Sound good. I believe you do need a consent for this procedure. It's a little, at least the retrograde, because it's a little bit more invasive, not so much the CT one. Ultrasound is also a great way to look at the kidneys. You can see obstructions. You can see if there's hydronephrosis or water on the kidneys. You can also see, just some gross abnormalities. Like if there's a tumor in there, it'll be more dense or less dense, or if there's cyst. So ultrasounds are really good too. If you're really wanting to figure out what's going on with the kidney tissue, you can biopsy it. That's usually done under CT guidance, not in surgery. It's a minor thing, minor surgery. Okay. I think that's it for our common urinalysis studies. It would be of benefit to you to review your clinical insights to see, is glucose normally present in the urine? No. Is protein normally present in the urine? No. How about urobilirubin? Maybe, and it tells you about the liver disease, if somebody has substantial liver disease, just little things like that. So I would glance over your urinalysis, okay? I'm not asking you to be doctors and diagnose a patient. I'm just saying know what they mean. All right, slide 26. There is a 24-hour urine collection process for a client. The nurse-assisted personnel inadvertently empties one specimen into the toilet instead of the collection hat. The nurse should continue with the collection of urine until the 24-hour period is finished. Make a note to the lab to inform them that one specimen was missed during the collection. C. Begin filling a new collection container and take both containers to the lab at the end of the collection period. Or D. Dispose of the urine already collected and begin an entirely new 24-hour collection. Think carefully. Answer is D. That is the correct thing to do. Dispose of the urine already collected and begin an entirely new 24-hour collection. Very important to do it all over again. All right. Slide 27. A nurse is caring for a patient who had an indwelling catheter removed 6 hours ago. The patient has not voided. What is the nurse's best action? Call the provider to recap, assess the bladder for distension, reassure the patient that this is normal, document the findings, and reassess. Well, the first thing you need to do is assess, and that would be assess the bladder for distension. The reason we are not calling the provider to recath at this time, because what if the patient hasn't been drinking very much for the last few hours, and it's not a matter that they couldn't pee, it's just they don't have any urine in there to pee. So that's very much the case. But yep, and no, this is not normal, so don't reassure the patient that. And we wouldn't just document these findings because they are abnormal. All right, I believe I have kind of gotten the main points out there. At least I hope I have. So remember, if it goes in, it must go out. So that is the end of today's show. I would just want to encourage you to create those mind maps that I mentioned earlier, including the risk for the condition, the signs and symptoms, or the presentation of the problem, and the treatment of it. What are the interventions? What are the teachings that you're going to do? And how does the diagnostic test that you just learned interplay into all of this? All right, if you have any questions, feel free to use a discussion board. I check it pretty frequently, or you can email me or text me if you feel desperate. No, just kidding. You can text me. I'm fine with that. All right. Thank you so much. Have a great day.